So first of all, I want to thank Professor Grigorieva to give me the opportunity to do this presentation. I met Professor Grigorieva at the last ORC meeting, and she asked me to do this presentation. So it's similar to the presentation I did at the ORC in Seattle in 2023. And the title is From Low Back Pain to Spine Way. You know, like me, that low back pain is the first cause of years lived with disability worldwide, okay? And mainly in Europe, in North America, in South America, in North Africa, in Australia. And so it's a very big problem, and you know that these results exist since 1990, when the first GBD has been published in the Lancet. If we follow the American guidelines to take care of low back pain patient, you have three categories of patients. You have patient who have non-specific low back pain, patient who have spinal stenosis or herniated disc, and patient with another specific spinal cause like tumor, like infection, vertebral fracture, or pelvis spondylitis, for example. And the two first categories represent 97% of the patients. And the problem is the term non-specific. Okay, because in fact, in the majority of the patients, you are going to tell them that they have a non-specific disease or a non-specific pain, and I think it's very bad for the patient, and it's a very bad signal for the patient. And if we compare to knee pain, we never do this. So never forget one thing. This is, for me, the most important sentence in medicine. Without diagnosis, any treatment is irrational. It's Hippocrates, more than 4 centuries before GC, and following after by Claude Bernard, the French scientist in the 19th century, and he was the first to prove that pathophysiology is the key event of a disease. Hippocrates thought that pathophysiology was very important, but it was unable to do the demonstration. And the first one to do the demonstration was Claude Bernard, and in between, it's in the 17th century, is René Descartes, who is the second one after Hippocrates to think about pathophysiology. And if we go back to clinical assessment of patient, when a patient comes with a knee pain, at the end of the consultation, you are going to tell him that you have knee OA, knee instability, tendinitis, meniscus pathology, ligament pathology, leading to a specific treatment. But in low back pain, when a patient comes in your office, he comes with the diagnosis of low back pain. In fact, it's not a diagnosis, it's a symptom. And at the end, you are going to tell him you have a non-specific low back pain, leading to a non-specific treatment. And this is terrible for the patient. This is terrible because, in fact, we are able today to isolate subphenotype of low back pain patient where the degeneration of the intervertebral disc is mainly involved in the pain process, the instability of a segment of the spine, the deformation of the spine, osteoarthritis of the disc, osteoarthritis of the spine are the main, in fact, lesion able to explain the pain of the patient. Okay? So, in fact, when we say low back pain and you have non-specific low back pain, what we did is a concept, and it's a terrible concept. It's a non-scientist concept. It's the concept of one size fits all. Okay. And when you have this kind of thing, one size fits all, in fact, it's that there is only one explanation to a very large phenomenon. Usually there is no science, there is no medicine, and it's an open door to charlatanism. So today, the diagnostic is non-specific low back pain. So after it's very clear, it's no imaging. Better to use color red flag with various sheets to fill by the patient, and non-specific treatment. And in fact, all this go in which way? In a way where medicine, we don't need medicine. And so it's an open door to charlatanism. Okay. And you know that probably low back pain is the most important domain of the medicine where you can find charlatanism. So all these considerations are based on the biopsychosocial model used for 30 years, but this model is not bio, it's only psychosocial. So we need to move from the non-specific world to the lesion world in low back pain, and thus going back to anatomy and biology, leading us to osteoarthritis. This is a disc of rabbit, a rabbit disc very similar to human disc, coming from my lab, and you can see on this disc, in the center you have the nucleus pulposus. Here you have outer layer of annulus fibrosus. Here you have cartilage and plate, and here you have subchondral bone. Okay, so it's very similar to knee anatomy. The difference is that you don't have synovial tissue and synovial liquid, but you have nucleus pulposus. And so if we want to summarize quickly the disc biology, there is two major events in the intervertebral disc degeneration. There is apoptosis, leading to the decrease of the matrix, extracellular matrix production, and there is inflammation leading to the degradation of the extracellular matrix components. And so it's very similar to what we observe in cartilage degeneration and degradation, as observed in osteoarthritis. So we did this publication, but it's 20 years ago when I was postdoc in US, okay, when we show that, in fact, apoptosis, so the cell death by apoptosis is one of the main events that we can observe in IVD degeneration. And this cellular phenomenon is regulated by mechanical stress via the mitochondrial pathway leading to cytochrome C release, caspase-9 activity, and caspase-3 activity. And so if we want to summarize here this cartoon, adapted cartoon from Yvan Rotin, published in 2010, you have inflammation and cell loss via apoptosis in the disc, leading to the degeneration of the disc. And so what we would like to do is to try to specifically regulate the inflammation and apoptosis in the disc in order to stop the IVD degeneration and to stop, in fact, IVD osteoarthritis. We choose to regulate first inflammation, but the problem is if we want to regulate inflammation in the disc, we need to detect non-specific low back pain patient related to disc inflammation. And for this, we have the response there is what we call the modic signal. Modic signal is hyposignal T1, hypersignal T2 on the end plate, okay? And this aspect is very rare in asymptomatic population. We can observe it in 5 to 40% of non-specific low back pain patients, and it's a strong predictive positive factor of back surgery, good results in back surgery. And so modic signal is probably predictive from a specific lesion related to low back pain symptoms. And there is, in fact, some similarities with the history of bone marrow edema in knee osteoarthritis. Okay, this is related to this abnormalities of signal is in fact the question of is related to local inflammation, and with dramatic with an increase in high sensitivity CRP, and clinically you have, presence of morning stiffness and a high duration of morning stiffness. So very similar to pelvis spondylitis, and with a worse painful moment during late night and morning, reproduction of the pain during the Valsalva maneuver, and it's when we observe only the inflammation modic, and when we compare to modic 0 and modic 2, and modic 1 is inflammation. Modic 2 is in fact the beginning of the well-being of the patient, with less inflammation and more fat in the disc. Okay, so in summary, the modic 1 signal changes on MRI seems clinically relevant in non-specific low back pain patients. This signal could be related to a local inflammation. Some similarities with acute flare knee OA can be observed. And so why not treating specifically this inflammatory process like in knee OA, because we are able now to detect patients with specific inflammation of a disc directly related to low back pain. And so what we did, we published this paper 10 years ago. It was in a case report in arthritis and rheumatism. And we were the first to demonstrate in a patient with, modic 1 signal, hyposignal in T1, hypersignal in T2, with low back pain. We do a corticoid injection, and after 1 month, you can see that the patient has no pain and the signal was normal. And so we were the first to demonstrate that a pharmacological treatment is able to treat a patient with a structural effect, via a structural effect. And so we published this paper in 2017 in Annals of Internal Medicine, where we show that, when we put some steroids in the disc here, we have a dramatic decrease of the pain. It's a proof of concept study, and we are now continue a bigger RCT. So T2 hypersignal observed in knee OA is very similar to the modic 1 signal observed in non-specific low back pain. You can see here and here. And so it's a little bit the same history. So in conclusion, modic 1 low back pain patients have a specific low back pain clinical and biological profile. And this is the concept of active discopathy. The active discopathy is very similar to the acute flare knee OA. We could change the term active discopathy to disc osteoarthritis. Intervertebral disc is a good candidate to a local treatment by injection, and corticosteroids seem to be effective. In a pilot study, it could be of interest to test specific intradiscal treatment like biotherapies, for example. And so the first line of active discopathy treatment is reassuring and explaining natural history over 2 to 10 years, the natural history of the modic, oral NSAIDs on demand, epidural glucocorticoid spinal injection could be of interest, and lumbar bracing and exercise therapy. And in second line is intradiscal glucocorticoids, and third line is other treatments and other molecule in experimentation and fusion. If you want to have another view of this new subphenotype of patient, you can read these three review, one in Annals of Rheumatic Diseases, one in RMD Open, and another one in Osteoporosis International. So thank you very much for your attention, and have a very pleasant Congress. And I hope that the next time I will come physically in Ukraine and in Kiev in order to deliver a new lecture and to show you and to see you and congratulate you. Vive l'Ukraine!